Hello, Kevin.
Hello.
Welcome to your monthly checkup.
Hello.
So, as you know, last time you got diagnosed with colorectal cancer, and then, a while later we took most of the tumor out through surgery, and we actually examined the slides through biopsy. And what we saw is you are SARIFA negative.
What does that mean?
You're good. You're at a low risk.
Oh, but I still have cancer.
Damn.
It's okay. So we all know cancer is really heterogeneous. There have been all these subtypes classified over the years, and they all have distinct molecular characteristics and maybe have effects on prognosis. So like breast cancer, you have triple negative breast cancer, or if ER positive, or for glioblastoma, you have your mesenchymal or your proneural subtypes. And for example, mesenchymal is associated with a worse prognosis.
Yeah, and that's part of what makes cancer such a tricky disease to treat, right? Like if you have like 20 patients who all have the same type of cancer, like they all have colorectal cancer, you can't guarantee that they'll all respond to the same treatment the same way or have like this same outcome,
progression, right? Or anything.
Yeah.
Let's say hypothetically you have, as Isabel said, a cohort of 20 colorectal cancer patients, all aged over 60, and you assign all of them chemotherapy plus maybe another drug, and only around half of them respond. So why is that? It's because there are these distinct molecular subtypes. There might be a subtype of colorectal cancer that is more resistant to chemotherapy, and it has been a growing concern in research to actually identify these subtypes so we can assign appropriate treatments.
So how would you go about doing that in colorectal cancer?
Yeah, so typically there are some cases in cancers where you can stratify them based on, do a blood test, and then if they have this protein circulating, you detect this protein, blah, 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 they're in the high risk, and then if they don't have it, they're in the low risk. But blood tests are pretty invasive. Like if you were over 60 and you wanted to know if you were high risk or low risk colorectal cancer, would you want to get your blood drawn every once in a while? It seems unnecessary and pretty invasive to me.
Mm-hmm.
And what researchers actually found in a recent study is that you can take H&E or pathology slides from the tumor biopsy, and you can basically look at it and then tell you if you're high risk or low risk, which is pretty incredible.
That is pretty incredible.
So
I'm astonished.
Biomarkers to identify it.
What?
Are there biomarkers?
Isn't that more invasive though? Because you have to
They're doing
retrieve
it
the
anyway,
tissue.
Because
Okay, yeah, that's
you try to
do biopsy or something.
in case it hasn't metastasized, you just take it out.
Mm-hmm. So what exactly are they looking for when they're looking at these whole slides?
Yeah, exactly. So they found this biomarker called stromal A-reactive invasion front areas, which is essentially if you look at the slide and you have, let's say, your cancerous cells and then your stromal cells, if they weren't really in contact or interacting with each other, then they're high risk, which kind of makes sense, right? Because a major mechanism of your body's ability to fight cancer is infiltrating the tumor with your immune cells. So if the tumor is not really interacting with the surroundings and it's just growing unchecked, then of course that's a pretty bad sign.
So something interesting that I thought about this paper was that along with the slides that they checked for SARIFA, they found that these same samples, the slides that were SARIFA positive, meaning that they had worse outcomes and stuff, it did not necessarily have association with certain genetic mutations that were typically thought to be this is bad for you if you have this mutation. It was a complete different category.
And they weren't associated with all these different other genetic markers that would normally be responsible for colorectal cancer. or other sorts of cancers.
Yeah, but also SARIFA positive tumors, they were associated with other certain molecular characteristics, like they had mesenchymal features, in which, like some cancers, they can reprogram themselves back to mesenchymal cells, which are able to, they're like stem cells. They can differentiate and proliferate much more rapidly than the original cells. So SARIFA positive tumors did exhibit more mesenchymal characteristics, which
Yeah.
makes sense. But they also they were associated with modifications in like their metabolism and their what's it called, stromal cell infiltration pathways. So there's probably some mechanism that inhibited the interactions between the stromal cells and the tumor cells. So maybe like removal of a surface protein, and then also possibly enhanced metabolism. So of course this is all stuff for future research. Like now that we can stratify it, then they can study the subtypes themselves, give them their own characterization, and then assign appropriate treatment, which is the whole purpose of it.
Mhm.
Basically stratify the patients into like low risk, high risk groups. So the patients with the SARIFA are high risk, so there's different treatments that can be made to target those patients specifically. Because not all, because like I think in the study they use something to predict like drug response
Mhm.
to the like patients with SARIFA, and they performed a lot more compared to like patients maybe with like with colorectal cancer but didn't have the presence of SARIFA. So not all drugs would work across like a whole like, cohort of patients.
Yeah, and it's great because it just improves treatment decisions and hopefully outcomes. Right?
Yeah.